Welcome everyone. I want to talk to you a little bit about some principles of visceral osteopathy before we move into looking at the assessment protocol for treating urogenital dysfunctions in a woman's female pelvis. Now first, you should know that there's a common saying within visceral osteopathy that any kind of assessment is in itself a treatment. Now why am I mentioning this? Well, it's important to know that when you're palpating a woman's pelvic area or any type of visceral area, whether it be pelvic or whether it be abdominal, your touch and your desire to engage the tissues in order to test for mobility, in order to test for adhesions, is in and of itself going to have an effect on those tissues. So bear this in mind, because when you start practicing these techniques in your clinic, I recommend that you schedule a time to run through this whole assessment, and that should be your assessment and treatment in and of itself with your patient that day. If you want to perform a complete treatment after that, I recommend that you schedule it on a separate day. Because as you assess your patient and as you're learning to palpate, especially at the beginning, if you remember back when you were in school, you know that we always tend to overcompensate or over-treat when we're beginning something because we're over-eager. So chances are when you're working on a patient, especially if you're accustomed to doing a lot of structural work or osteoarticular work as an osteopath, you might need to learn how to lighten up your touch a little bit. If you, when you're palpating and testing your patient, you're heavy-handed, then you're actually having an effect on the organs themselves. And when it comes to visceral osteopathy, less is more. That means that you want to engage the tissues to the point that you feel a restriction and then hold it, perhaps engage a little bit more release, but no more than that. We don't want to traumatize the tissues. We don't want to do anything that can cause them to go into a reflex spasm. So just when you have the urge to go a little further and do a little more, stop. At the beginning, remind yourself of the adage, less is more. I want to mention this to you because remember we said that some people with regards to the bladder might be in a hypertonic state whereby they're having difficulty releasing urine. Not everybody is urinary incontinent whereby they're releasing too much urine. They might actually be in a hypertonic state. Same thing with the uterus. You might be working on a mother who's just given birth. You might be working on women who've been through various types of traumas within the pelvic area. If there are adhesions or previous inflammation, it means that there's been trauma to the pelvis. And chances are the women that you're working on are going to have something like that in their history. So what we want to do is we want to coax the tissues and coax the organs into releasing, into regaining some mobility without going too far or too hard and without traumatizing them. Once you become accustomed to working with these techniques, you'll be able to use your judgment in knowing how long and how hard to work on a patient. And you can also watch your patient's face and ask for feedback. Whenever I work on a patient, as soon as I engage an area, whether it be because the bladder is sitting heavy down on the perineum floor, or whether because the uterus is stuck in an anteverted position, as I start mobilizing the organs, and as I start having an effect on them, there's so much neural sensitivity in that area that the patient, in fact, is going to be able to say to you, oh yeah, I feel that. So you're going to know just when you will have engaged an area that needs releasing and when to hold it and then when to allow the tissues to just somewhat melt under your hand and then allow the organs to fall back into place. So let's go ahead and let's look at some of the steps in this treatment protocol and you'll understand exactly what I'm talking about.